Excited for everyone to be here for our next episode of Between Two Allens today. We're talking about mental health in Oklahoma, and I'm really happy to have you here, Brittany. Brittany Hayes is from Healthy Minds, and if you could just tell us a little bit about what you do for Healthy Minds, what Healthy Minds is, and tell us a little bit about yourself.
Sure. So Healthy Minds, I'm the policy director at Healthy Minds. We've been around now for about 7 years, and we were really tasked with increasing access to mental health in Oklahoma. There are around 17 agencies that do mental health in Oklahoma, and the perspective of our original funder was there needs to be people who are thinking about mental health all day long, because mental health is really the asterisk on every other issue. You can't talk about education without talking about the impact of mental health. You can't even talk about the economy without talking about like the mental health of workers. You can't talk about the criminal legal system without talking about the impacts that mental health has. And so my role is to look at mental health across a couple of different strategic plan areas. So we think a lot about mental health in the workforce. Do we have enough providers to provide the services do we need? We think about affordability and accessibility. Are you able to see a provider regardless of who your insurer is, at an affordable cost and in a timely manner? We also think a lot about avoiding higher levels of care. So we don't want somebody's first interaction with a mental health provider or mental health treatment to be in an emergency department or in a jail cell. And then we also think about children, youth, and families. So part of my background was as a teacher. And so you can't really think about mental health without thinking about the family structure. You can treat a child and make sure that their mental health is taken care of. But if you're not looking more broadly at the family and arguably more broadly at the community, you're not actually able to get to the root of why a student or a child may be experiencing the issues that they're experiencing. And so really our job is to create an environment and give advice to folks like you or other stakeholders to improve things like access and affordability.
My first year at the Capitol, they have all these different kinds of caucuses. We've talked about caucus before, and there was a mental health caucus, and I wanted to go to everything, even rural caucus, which was great as well. But I loved how organized the mental health caucus, and you guys were a big part of that. Could you tell us a little bit about that, how it got started? And I know you have like a sheet of laws or things or policies that you've had changed. Tell us a little bit about that.
Yeah, so we started the Mental Health Caucus in 2019, and it was really with the understanding that a lot of people inside and out of the Capitol have connections to mental health, but they may not be drawing that connection to the way they think about the work that they're doing. And so we wanted to highlight that mental health was an issue worthy of conversation. And so our approach with that was really intentionally bicameral, bipartisan, because mental health is bipartisan. Everybody's family, regardless of how they vote or what their priorities are, has some sort of connection to mental health or substance use. And so this was a way for us to get folks who were already cognizant of that interest in the same room in hopes that they would have broader conversations with their colleagues that can help them draw those lines. But I'd be lying if I said that mental health statute also isn't very complicated. And so it was a way for us to really think and be intentional about the way that we're framing these larger issues. A lot of times big change isn't possible because no one's working on the same definition. And so this was a way for us to have sort of like a mental health 101 or vocabulary and get somebody on the same page so that our legislative agenda could be more effective. One of the things that we really focus on is mental health parity, which in a vacuum means absolutely nothing.
No.
But when we talk about it, it's really making sure that our insurers are treating mental health the same way that they're treating physical health. So if they're providing a service and if it's timely and if they have a robust network in the physical health side, then it should be just as robust in the mental health side. And so we laid the foundation in caucus to really help folks understand what were the responsibilities of insurers. Were they fulfilling those responsibilities? And if they weren't, what kind of changes could we make to make it a little bit better?
So one of the things that you mentioned was workforce, and that I feel like in every area that I care deeply about, the workforce shortage is forcing us to not have the ability to provide those services. Is that what is kind of y'all's experience with mental health workers?
So for mental health workers, there's a lot of aging out, right? A lot of our doctoral level providers are in that baby boomer era, so they're facing retirement. and we are not sort of shoring up that workforce at the same level that we were. And so we've already been working with master's level professionals as much as possible, as opposed to some of those doctoral level professionals. But I think the other thing that folks don't understand in the physical health space, we have certified nurses assistants and other people that support practices. And we have those in behavioral health, but they don't have the same sort of like respect, or they don't have the same sort of wide acceptance. So we talk a lot about peer support specialists, who are individuals who have lived experience, who can walk a person through the system, or case managers, who are often the individual that's guiding somebody, not just between appointments, but really through the process of recovery and healing. And so when we think about workforce, we really think about it across that spectrum. And we utilize the caucus to increase the amount of funding for psychiatry residencies, because at some of our universities, they were getting like 6 times the number of applicants than they had slots for. So it's not that people don't want to practice and don't want to practice here. It's that they didn't have the spots to do that training. And the other thing that we really recognize, especially in the psychological workforce, is that we don't have any like postgraduate internships or postdoctoral internships, which means that the folks who have studied here are not staying here. They're going somewhere else and then settling wherever they want to do that internship. And so we've got really specific changes we'd like to see across different certifications and licensure types. And we've been pretty successful in making those things happen. It's just about then the implementation. That's the other thing I'll say about Healthy Minds is anybody can go in with enough momentum and get a bill passed. It's really about what happens after that bill's passed, because implementation often is more important than the idea itself.
Yeah, that's exactly right. Because you have to have everyone that's actually going to be the direct contact with someone else know exactly what that bill or what the change you wanted. So important, so important. I got a chance to judge at Generation Citizen. That's when all these different schools and high school students come together to talk about what they can change. The amount of projects that were on mental health was just incredible. Gun violence was also one that was, which I feel that there's a part of that as well that goes in. There was a young student that asked me to, actually emailed me. I didn't know it was him, and we ended up running into each other, and they're talking about what they do. Mostly what these kids were asking for was that peer-to-peer. Like, and when I was in high school, 19 clickety-clack, you didn't really talk about, what bad day you were having, And it's just so incredible that that's happening. And how do they build it and grow it? Please tell me about this peer-to-peer. I was parent support, so a little bit ahead from someone who had a diagnosis. It's always good. But with mental health, people don't look at that as so important.
Yeah, and I think there's a couple of layers there. First, we should feel incredibly thankful and respectful towards younger generations who are starting to destigmatize mental health, right? Talking about your day and how you're doing and the importance of that. Some of the older generations still haven't been able to accomplish. But I think when we talk about peer-to-peer, it's really about having that safe space. Now, there are states who do have youth peers, and that's part of their statute. Oklahoma was later to come on to peer recovery support specialists, so it makes sense that we don't quite have like an organized youth peer service, but there are agencies like Youth Services Tulsa who values having those peer-to-peer interactions, because, your parent can tell you something 100 times, but if your friend comes alongside and says the exact same thing, that's when they're going to listen. And so I think that's why the message of prevention and messages are so important to be more broadly, broadcast, for lack of better words, so that when those friends are in the position of being a peer, or when they've had those experiences, then they're well-informed, and they can be well-informed when talking to friends.
Thank you. So one thing that we, I'm a freshman, so I just went through my first year, and one of the major issues at the Capitol this year was the consent decree. And so if you can kind of let people know a little bit about that and the impact at the state level.
Yeah, so about 2 years ago, there was a lawsuit filed. And basically that lawsuit said that for those individuals who were feared to be incompetent to stand trial, there were really long wait times. And there are 2 parts of that process. One is the evaluation. So when a provider comes in and basically answers some questions about whether or not somebody can aid in their own defense or understands the consequences of what they did. So we had really long wait times to see if somebody was even incompetent. And then the back half of that is, if they're found to be incompetent, can we provide services to get them to competency so that they can undergo their trial or put in a plea or whatever it may be? And parts of those consent decrees had a lot to do with data and tracking. It was, do we know where these people are? One of the barriers in Oklahoma to better understanding that is that we don't have a statewide jail database. So I can't tell you. So let's say Jimmy Allen, if you're in Tulsa, there's a pretty good chance that you could have also been arrested in Washington County or Osage County or Creek County or Rogers County, but nobody can tell you that. And so one of the barriers to getting an accurate count and an accurate estimate of how many people are undergoing competency is shoring up that data piece. Can the department say who this person is, what their charges are, how long they've been waiting, and really how long they can expect to be waiting to be evaluated? And so the decree basically requires the state to shore up their services to create a predictable process so that when somebody goes through this process of being evaluated, and then if they need competency restoration services, how long it's going to take them to be restored. I mean, we've got all of these constitutional rights, like a right to a speedy trial. And these delays not only harm those individuals and their mental health, but being tossed between different systems and different settings can also be really harmful. There are things that other states do that I think Oklahoma is looking at or could look at. One of the differences in Oklahoma is that we do competency evaluation and restoration for misdemeanors. So we've got individuals who it's their 14th time stealing ashwagandha from Sprouts, right? Like, not really a threat to public safety, really just needs mental health support. They're taking up these resources to be evaluated and then restored for a misdemeanor that's going to carry maybe 30 days in a county jail. The other thing that can be happening is outpatient restoration treatment. So a lot of these folks, and I think it's well known and understood that folks experiencing mental illness are far more likely to be the victim of a crime than the perpetrator of a crime. So a lot of these people just need a safe setting to land. And the safest setting and the best setting to get treatment in is one that you're familiar and comfortable with, or the one that's the least restrictive. And so there are states, especially in like Minnesota, who if you're charged with a nonviolent felony, it's better to treat you in an environment that you'd be going back to.
Yes.
Why are we treating people in this like jail environment, setting them back home and expecting all of those lessons to easily transfer? We're not giving them those skills necessary. And so there are states who have done really well with doing that competency restoration in the community and then continuing on with the case. One of the big issues in the consent decree was also, what is the role of doing competency restoration treatment in jails? One of the things that we don't have is a jail formulary. And so a formulary describes like a list of medications that the jail is willing to pay for. These medications are not cheap, right? Counties aren't flush with cash, that they love spending money to send to different manufacturers. But the question here is, can we or should we use the jail as the environment to start that process of evaluation and restoration? Because one of the problems that the lawsuit highlights is we can see an individual who has been evaluated, then they've been sent to the forensic center up in Veneta to be restored. That person is then restored. We've declared that they're ready to go through their trial.
Back, everything's good.
Everything's good. They get sent back to the county jail. They wait, and the county jail either doesn't have the medication that they were restored on or doesn't have the medication at all. And so these are sorts of the questions that the state is being asked to answer. So far, it's been a big challenge. The state's going to be getting some fines, but Oklahoma is certainly not the only state that is under a consent decree for competency.
Well, and then just about the waiting, all that time for whatever they were put in jail for, he probably has been waiting longer than maybe that sentence would have been.
Absolutely.
My question always is that, I'll get to medication in a minute, but, the families that are waiting or helping or out of money or don't know how to support sometimes the family support goes away after a certain number, especially if they're not from Oklahoma City or close, and have to come in from wherever. I just think that when we receive people back, we still need to support that family. And I think there's a missing piece there as well.
Well, and there's also folks who get sent there and they're not able to attain. So basically, they're never going to be competent. And we don't have a setting to send those folks to. And so we're thinking about like a long-term care setting. They may or may not be a danger to themselves or others, but they're not safe in the community. And so what happens is the forensic center is now filling up with those folks who are never able to attain. So yes, we're increasing the number of beds in the forensic center by like 80 or 86. But if we keep on having an increase in the number of people who aren't able to attain, then we're just building beds to continue to house people in that setting instead of prioritizing building a setting to basically a step down facility for those people who aren't able to attain.
Yeah, I heard a story about someone who did end up going to jail, but it was based on not being able to get medication, not because they didn't want to take it, but the accessibility or maybe affordability, especially with what's happening now. That seems to be a real problem. Can you talk a little bit about medication and maybe how it's used in Oklahoma? Some barriers that there is a big question, but I just think that we don't talk about that medication piece enough. And as not saying that everyone needs to be medicated, but there are overly medicated, but it is a piece. And when that falls off, what happens after that?
Yeah, I'll give another context from the jail setting again. So county jails often can't afford these kinds of medications. These are the medications that are going to stabilize an individual, or for somebody who has substance use disorder, you can even start them on like a medication assisted treatment, which is basically to treat opioid use disorder. Those medications are extremely expensive. And if you're looking at somebody who uses a long-acting medication, sometimes called a long-acting injectable, they're prohibitively expensive for a county jail. Doesn't mean that the person doesn't need it, it just means that the county can't afford it. There's some flexibility in federal law now, it's called an 1115 waiver, that would allow jails to be reimbursed by Medicaid to provide medications for those individuals if they're within 30 to 90 days before release. The state can decide if it's 30 days, 45 days, 60, whatever it is. But that's an opportunity that Oklahoma has not yet taken that would provide jails the flexibility they need to provide medications and treatment for individuals. Often for somebody who has like a substance use disorder, that couple of weeks after they're released from jail is the most dangerous. They no longer have the drug tolerance. The risk of overdose is immense. But if they're in this jail setting, even if it's for a misdemeanor, and you can get them connected to services with a provider on the outside, and the jail can get reimbursed for that, and the provider can get reimbursed for that, and you can also start using medication that the person consents to in that setting that the jail gets paid for, you're not only making that jail setting safer for that person and for jail staff, but you're also creating a really strong connection for that person when they are released so that they have somebody to walk out to.
So what would it take for our state to do that?
Yeah, so the healthcare authority would have to file the Medicaid waiver. Basically, the waiver can't cost more than the state would be getting in federal funding already. But when we think and talk about these higher levels of care, that's where that cost offset comes. Basically, the feds have told us if you follow one of a couple of states, your application is going to be approved. But the state's been kind of looking and talking about this for 3 years, but it's about time to just go ahead and get it done. We know that our jails are being used as de facto mental health treatment facilities, and that they don't have the money to either pay for the medication or to get services inside the jail walls. And this is a way to reduce the burden on the counties and increase accessibility for folks.
So just thinking about the consent decree and the plan, this would probably be something that would be huge in trying to move forward with it.
So one of the other questions I just get a lot on doors is people wanting mental health services. Yeah. And so one of the things I've been trying to learn over the last year is how we deliver mental health across our state. So can you talk us through kind of a little bit about that delivery model that we have?
Sadly, the first question is, who insures you?
Yeah.
And that determines care. So if somebody is on Medicaid, then they have easy access to the certified community behavioral health clinic setting. So if you're in Oklahoma City, you're looking at your Hopes, your Red Rocks, your North Cares. If you're in Tulsa, you're looking at Family and Children's or Creoaks or Counseling and Recovery Services or Grand. But as it stands now, each of those areas has an assigned community mental health provider. And so that's the easiest door for individuals who are on Medicaid. If you are on commercial insurance, that question gets a little bit fuzzier. A lot of people start by going to their primary care physician. Some primary care physicians are really in tune with mental health needs. Some of them even do screenings in their offices that tell them if there needs to be a referral to a mental health provider. And in fact, there's going to be a bill that's going to be introduced this year that would require folks practicing in the primary care space to do one of those screenings that they would get paid for, but would basically let them know whether or not that person is experiencing anxiety or depression. And honestly, in the primary care setting, primary care docs can take care of the majority of mild and moderate mental health. That next step in the primary care setting is integrated care. And you'll be hearing a lot from Healthy Minds about this. We were a recipient of a TSET grant that's going to introduce collaborative care to clinics across Oklahoma. And basically, it empowers those physicians who are working in the primary care setting to deliver behavioral health services, basically with a psychiatrist on their shoulder, right? It allows them, and they do case management with this psychiatrist, who's often located in a metro area. So we're really thinking about rural Oklahomans and how they access behavioral health care. If they go into their primary care doctor and they have a severe and persistent mental illness, maybe they should be referred someplace like a CCBHC where they have a psychiatrist, but what can that primary care physician be doing to help in that person's care? And that's where collaborative care really comes in, is like this co-located model of, by talking to your primary care physician, you're also talking to that psychiatrist on their shoulder so that they can work on your medication management with you without you having to drive to the metro to talk to them. And so we're really excited about rolling that out to additional clinics. We've already rolled it out to clinics before, but it really just allows us to scale mental health in the place where people know best where to get those services. Now, for somebody who's experiencing a mental health crisis, Oklahoma has come really far, especially in the metro areas, on urgent recovery centers. And that's a place where somebody can walk in if they're in mental health crisis, where they'll be stabilized in under 24 hours. So it's really a mental health chair. Somebody's going to sit, talk to you, do a mental health evaluation. A lot of those people are released back after, up to 24 hours. If there is a higher level of care needed, then we have crisis stabilization units, which are 5 to 7 days, which provide those settings. And that doesn't matter what your insurance type is. It's more that early intervention is where we should be going. Like the first time that you seek mental health treatment should not be in an urgent care or an emergency setting. And unfortunately, we've created a system where that ends up happening more often than we'd like to see it happen. But that's generally how people begin to get access to services. There are obviously a lot of wrong doors where people end up getting services, like either in jails or, but that's kind of where it happens. But that's where the workforce issues really come in.
Do you have enough psychiatrists?
No.
Yeah, I was like, when you said that, I was like, wow.
No, and not everybody needs a psychiatrist.
Right.
That's the other issue too, is we make it really easy for people to think that like they always need a psychiatrist or they always need a psychologist. Our master's level professionals are great at what they do. If you do have a relationship with a psychiatrist, hopefully it's not like the weekly therapy relationship with a psychiatrist, but it's really about thinking about that workforce more broadly and how they're utilized. We don't have enough psychiatrists. We don't have enough psychologists. We don't have enough social workers. National polling would tell you that we have enough LPCs, but licensed professional counselors. But until 2 years ago, nobody was asking those folks if they were actually using their license. And so now we changed the law so that people have to tell the licensure board if they're using their license and if it's full-time or half-time. Like both of us have teaching licenses and we are not in the classroom.
Correct.
But the Department of Ed could tell you that we're not in the classroom.
Right.
There's not the same sort of thing happening across the behavioral health licensure types. It's just, do you have your license? We're going to count you towards availability, and that's not an accurate reflection. We're working on a report at the beginning of next year that's going to better align the updated data with the true reality of provider availability in Oklahoma.
Well, I'm so excited to just hear about, like I said, when I first came to the Capitol to talk about policy, because you were looking at the whole state. And so legislative season is coming up. You and I talked about 988 earlier. What are some of those which I think is a priority this year? What are some other priorities, or tell us the priorities this year of Healthy Minds?
Yeah, so we have a couple of different priorities. We've talked a lot about peers and case managers already today. Right now in statute, you have to be employed at a certain place to maintain those certifications. We don't think that you should have a place-based restriction on that certification. And so getting rid of that requirement. Cities are stepping up and doing a lot more co-response and a lot more 911 intervention. And right now, the statute wouldn't allow them to hire somebody who could maintain their certification after that year. So that's one change. Also looking at, and this is going to sound weedy, but when an insurer makes a decision about whether or not to cover your care, they rely on criteria. These criteria are often proprietary. Sure, a physician may be able to log into a portal and see what those criteria are, but you and I have no idea what those criteria are. And so we're introducing a bill this year that would require insurers for mental health to follow these fair, transparent standards when making those utilization review decisions. It might not all happen in 1 year. It would be a really big change. But what we've seen, especially in the mental health space, is these standards are the reason that care is denied. And that is what delays care and pushes it to higher levels, which are more expensive, more onerous to the individual, when we could be doing these things earlier on. So it's another piece of that early intervention. We're also focusing, like I said, on that screening portion. So we're requiring folks who are providing services in the primary care space to deliver a screening to each of their patients once every year. We're really excited to see primary care. I mean, Oklahoma's done great at expanding primary care. We just want a little bit of a mental health asterisk on that too, making sure that if that's the place that somebody's comfortable going to, then they're going to get what they need there. 988 is another big one. Right now, if you were to look in statute, which I'm sure everybody does all the time, that 988 doesn't exist there. And so if we want to continue to build relationships with 911 and build relationships with law enforcement, we've got to operate on some, definitions so that everybody has an understanding of what's going on. So that bill not only lays out the definitions of 988 and who all the players are, but it also creates a mechanism to continue to fund those services. Right now, we fund those services with federal grants. That federal funding ends at the end of the next federal fiscal year. So now it's time for the state to step in and take the reins on 988. Right now, we contract with Solari. We expect that to continue. It's more about where the money is coming from to pay for mobile crisis, to pay for the call center, to pay for the technology. That's in the background of all of that. But the other piece there too is if you are on commercial insurance, your commercial insurer doesn't repay the state if you use a mobile crisis response. Those aren't free. And so written into that bill also is the requirement that if a person with commercial insurance utilizes those services, then there's some sort of recompense from the carrier, because the state can't continue to pay medical costs for somebody who has their own insurance. So that's a piece of that as well. Another one of the pieces that we're working on shores up court committed outpatient. So right now, we've got folks in the system who have a condition called anosognosia, which basically means that they are mentally ill, but they don't understand that they are mentally ill. And sometimes they are a danger to themselves or others. An inpatient setting may not be appropriate for them. But there probably should be some oversight to make sure that they're going to their appointments. It's not a system that's right for everybody, but right now it's a system that's right for nobody. And so it shores up some of the requirements in that system so that a person, if they have a mental health advance directive, that's part of their treatment plan. It's not something that we just toss aside. Or it requires them to have counsel when they have one of those hearings. It lays out the requirement for what a treatment plan is. So ultimately, it's not about getting more people on court-ordered outpatient. It's about making sure that if they are, everybody knows what their responsibilities are, the person's rights are protected, and there's a better playbook. Because ultimately, we've got a system that is operating in 77 different ways across 77 different counties, and that's not sustainable. Because people don't know where the county line is.
Oh, yeah.
No, no one knows. I do think that mental health is, and you had said it, is so important in every area that we look at, and there are some areas that we don't, get to as well as we should. I was sitting around a table with a bunch of women, and just our experiences with postpartum. And I know we all should, but it's something that, I mean, even as a mom who had a child already, I had no idea what was happening. And of course, it's all put on us that we should know because we developed, we created a baby. And so my question to you is, how do we, our younger generation has done that about breaking down those walls and talking about mental health. What's something good? You may not have an answer, but I think it's so good that we talk about it, that women can just say, I need help with this, because it's something that can be pretty harmful to families if it goes untreated.
I think we are in a space now where women feel comfortable in saying that they need help. I have a 3-year-old, so not postpartum, but like close enough. But the thing that I remembered is going into my pediatrician or my daughter's pediatrician and going into my OB-GYN's office, them both handing me a screening, and then my insurance carrier denying one of them because they were too close in time. Because forbid that I try to schedule those appointments on the same day, right? And so I remember the process of...
Or don't even schedule it at all.
Or don't schedule it at all.
Because of, yeah.
And so it's sort of this question of, we can break down all of these barriers in the community, but if we don't break down the very real barriers that exist but aren't fun to talk about, then you're just squashing all of the destigmatizing in the community. And so when we think about like pregnant and postpartum women, a lot of those issues don't just start postpartum, right? So we need to be thinking about mental health even in the perimental health stage or in the perinatal stage, or even as a mom's pregnant, because it feels like there's no support in those stages. And as much as our OB-GYNs want to be helpful, they are not mental health specialists or experts. So in other states, so similar to how we're doing a screening requirement for primary care, other states have similar screening requirements, but in that OB-GYN space.
That's good to know. That's something that we have to work on then.
Yeah, I mean, and technically, so this is an issue that we've looked at. My number 2, my senior policy analyst, is also postpartum. And so this became a really big issue for us as we were going through this system. And right now in statute, there is a requirement to do screening, but we pulled the data and only, I think it was 30% of those screenings are actually happening. And so it's not about, again, it goes back to that conversation around implementation, that you can have the requirement, but if we can track that it's been 30% over a number of years, what have we done to intervene to increase that? Does that mean that we have to increase the reimbursement from whatever it is by a couple of dollars to see that number move? I mean, if that's what we got to do, then that's what we got to do. And so I think it's more about like taking the time to recognize those patterns, because you can have a rule and statute all day, but if nobody's tracking how it's going, then it doesn't matter if it's on paper. And that's coming from a lawyer.
The reimbursement's a big part of it.
Reimbursement's a huge part of it.
And it's one of those things we don't like to talk about a lot because it's conversations and it's money. But I think, maybe that's what we get to is show what it does to our budget when we do spend a couple extra dollars with reimbursement, with that mom. So thank you. That's a big thing. And I heard a young mom talk about, postpartum, and I thought, I'm happy that they're talking about it, but it just seems like we're still not moving numbers on maternal health.
Yeah, it's one of those things where like we're expecting community to fill the gap, and community is a great gap filler, but it's not the only gap filler.
And community's tapped out too. I mean, there's not just and of course moms usually are last on the list. I'm not being negative. It's a reality. We choose to do it ourselves. The other thing that it touches, which brings in women, is having a conversation about domestic violence. We're still number 1, but going back to those young men or young women, and without having that mental health support, trauma just begets trauma.
Yeah.
Can you talk a little bit about trauma and how that falls into a bigger picture? Is consent decree or violence or whatever?
Well, and when you think about, I think, domestic violence, it's not only about like the victim, it's about the perpetrator, right? Like there are so many mental health issues in that space too. While we've broken down barriers with young people in mental health and women have created community around mental health, especially in the postpartum stage, you don't have that same sort of community with men. And married to a blue collar guy, so even less of a community around mental health. You have high rates of substance use, you have high rates of things like depression and anxiety that are self-medicated, right? And so you see this cycle of not having a community. And there's an article I read a couple of years ago that like men have less friends than they've ever had.
Oh.
I mean, there's just like no community, let alone mental health community. I mean, everything's done through like a headset in a first-person shooter game, right? There's not the same sort of avenues that we used to have. And so I think it's not only about like building that community and access. I mean, even if we could get men into the door of a primary care physician, making sure they're ready and able to have the conversation with a person who's reticent to be there in the first place. But when I think about trauma in Oklahoma, I really think about like the generational element of that. Oklahoma is number 2 or 3 in grandparents as parents, right? So where grandparents have had to step into the role of caretaker for their children's children, and sort of what that means for the generations, especially coming through our schools, are our teachers who are already doing way too much. Also, not only trauma informed, but trauma responsive, right? I feel like everybody, now you have rooms of people where 90% have heard about ACE scores. But it's not just about ACE scores and what's on a piece of paper. It's, do you know what to do after you've read that piece of paper? Really, it's just a number on the bottom of a sheet. But if you don't have services in place to really take care of what you've identified, then you've identified a problem that you no longer have a solution for. So that's the group that I really think about. I think about like men who don't have community, and then I think about those sort of fragmented family structures where, I mean, grandparents weren't intended to be raising 2 and 3-year-olds.
Yeah.
And now those 2 and 3-year-olds are entering pre-K and kindergarten and first grade with issues that teachers don't know how to approach on a behavior level, right? And if you can't control the behavior of your classroom, then anything that you try to teach them will not stick.
We've picked up so many, like everything, it touches everything, and even bringing education into it. All of our numbers that are the top of the worst or the bottom of the best, I think mental health touches each one of those numbers.
Yeah, and really like part of what got me into mental health in the first place, I was a classroom teacher for 5 years in a Tulsa suburb. In 1 year that I was teaching, we had 5 or 6 kids who were my students attempt suicide. Really alarming. Didn't have the resources those students needed. Even if we did have the resources, the community was one where mental health was still really stigmatized. But it's also about like IEPs and 504s and how we implement those and recognize and follow those rules and rights. Where when I was a public defender intern at the Tulsa County Public Defender's Office, the very first person that I interviewed independently was a former student. I knew their file. I knew how many times they had moved schools. I knew the issues that parents had. I knew sort of the issues that the student had. To then see them in this setting, like at how many different intercept points, me being one of those intercept points, could we have avoided having this conversation in a lawyer-client relationship? And when we think about systems more broadly, like identifying those intercept points where if we could have identified that and had the resources to address it in the school or the classroom, they wouldn't be sitting in that jail setting.
Yeah, I mean, we talk about at the Capitol all day, every day about preventative services. I mean, it is because the payment that we are paying in our state, I'm sure if there was like a pie graph, it would be like 70% not preventative, 30%.
That's really generous.
That's very generous.
It's probably like 88-12.
Yeah, and
We're reactionary.
it was very reactionary. And, you know, I think everyone's heard Upstream and that movement. But I think people don't understand. And that's, when I hear all of these things at the legislature, people are like, what are you going to do about it? And I always think, like, our body is really meant as an incentive funding system, that we incentive the outcomes that we want to see. And so, I'm grateful for y'all's work in trying to push the needle towards that preventative incentive. But that costs money. And,
It does.
that's where Oklahoma is going to have to, at some point, determine what cost they're willing to pay to move the needle in areas that are costing us so much and also hurting our community so much,
Yeah.
So
Yeah, the community, so my counterpart at Healthy Minds was the director of prevention at the Department of Mental Health for 17 years. So I've heard more about prevention in the last week than most people have heard in a lifetime. But we have a prevention paper coming out around where you can best invest to see long-term outcomes. Because we think a lot about like green spaces and parks and community spaces, but so far it feels like we've spent so much time putting out fires that if we're working on this prevention stuff, like we can feel the fire and see the smoke, but it's hard to divert your attention to that prevention space and then ultimately decide how much of that finite pie you're going to give to that. But we'll have some ideas for you all
I love
coming
that.
soon.
Well, and we rush, every two years we're on that cycle in the House, of looking to see what to do or what idea. You hear a lot of legislators say, "I have an idea," and it's like, "Whoa, what's it going to look like at the front step at the door?"
Yeah.
But it's nice to have you guys that are just looking at the whole continuum and seeing it. We can't get everything done at one time, but I even think just chipping away at some of this can definitely change a whole bunch of lives. So I'm very truly grateful that you're there. Can't wait to here I'm saying can't wait to be up there again. But I'm urgent for change in some ways, and not change that's quick and not thought out. It has to be thought out, and I'm ready to start for that.
It's
change.
not always going to be flashy.
No,
I mean,
no.
It's not the bill that's the most interesting to read that ultimately has the most change. And I say that having written a bill that I know is like too dense for people who don't work in insurance to understand because it's not their area. But sometimes I feel like we let density be the enemy of progress.
I love that.
Where like just because we don't understand it, it means that it's not worth considering. And there are so many things that we can address if we just sit in a conversation we don't totally understand to gain more competence or understanding.
Well, you can sit in that, but you also have to have them listen.
Yeah.
It's who
Yeah.
you're listening to as well, I think is really big. And you guys have been definitely so, like that continuum, that's stable, that, and including people to listen and work together. So I do appreciate that. So, is there any other questions you have?
No, I think we're
I mean, we
good.
talked about it all.
Yeah.
And I wrote down so many things here that we talked about. So I appreciate it because it does touch all of our lives, especially in our state. So we ask our guests to ask the Ellens a question at the end of our episode. Do you have a question for the Ellens?
I do. So we're a little less than a week before Christmas. And I swear I've heard the phrase Barbie Dream House in my house no less than like 25 times a day. So tell me about either your favorite gift as a child or, because you're both parents, the gift that you most remember your child like having the biggest reaction to, the thing that they loved the most. So either your favorite or because we get so much joy from seeing our children.
Well, monumental for Ellen Clark Pogmiller was her 6th grade gift from my mom, and our Santa brought me contacts, and I no longer had to wear glasses. And that was a first step in my transformation from roughness to a little less rough. So I remember that so vividly, getting that gift.
I guess there's a gift that I'm giving this year that I really am happy that I'm giving. It's my son asked for my cookbook, so I'm making that for him. So that's something that I'm giving. But I remember when I was 7 that my grandma and grandpa used to give this year's, you guys are both too young for that, this year's lookbook for Christmas.
Yeah.
And they would have us circle which ones we want to put our name by it. And there was this shirt. It was pink with black pinstripes on it with a black bow and white collar and cuffs. And I just thought it was so pretty. I didn't think they'd get it for me, but they did. And I only wore it once because I just loved it. It was one of those. So it was something that kind of taught me about gifts and what you want, It probably maybe wasn't my style or something. I don't know. It was beautiful, but I just never wore it. So it just is one of the, I'll never forget getting that gift. I didn't think they'd give it to me. But anyway, that's nice. How about you?
When I was like 3 or 4, I got an easy bake oven.
Oh.
And I was like that, it was over.
Those little pans. I mean,
Yeah.
all that work for one little bite. Yes.
But I was fiercely independent. If I could do it myself, then the easy bake oven was the safe way to do it.
That was your avenue.
Okay, that was my first sentence as a child, do it myself. And then it was yours too. I did it myself.
Yeah.
Well, thank you so much. That's really nice, that question, bringing back those really great feelings, about gifts. And thank you for asking that question. And thank you for being here today. And I know we're probably both going to look forward to seeing you at Capitol and asking you a ton of questions.
Absolutely.
And let us know if you need any of our help as well.
Yeah. Thank you so much for
Thank
having me.
you.